COPD, short of breath, coughing all the time. Do you have COPD?
Welcome to another episode of Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzo.
We have a guest today, Dr. Lawrence Chow, who is a respirologist with us, kindly graced us with his presence and his time, and is going to teach us today. Thanks for coming, Lawrence.
Dr. Chow, there is a rumor going around that the internal medicine types, like the respirologists and that, are much smarter than orthopedic surgeons. I think it's true, so I'm very glad. I'm very glad that you're here to talk with us today about this topic.
And today we're going to talk about COPD.
Right.
So let's start at the beginning. What is COPD?
Well, COPD stands for Chronic Obstructive Pulmonary Disease. It's really quite straightforward. To make the diagnosis, we have to show airflow obstruction, which basically means you have to do this little test called spirometry. A little gadget, you just blow hard into it, take a big breath and blow all the way out as fast as one can do it. And this is to see whether you cannot empty out your lungs as quickly as you should. And if you cannot do that, then you likely have COPD, though there are other possibilities like asthma. So put in the right context, that's how we confirm the diagnosis of COPD, chronic obstructive pulmonary disease.
Okay, so what are some of the symptoms someone might have? If one of our viewers is thinking, boy, I wonder if I have COPD, what are some of the symptoms they might have?
For most patients, usually they present with shortness of breath. That's how they sort of see their doctors. Often they would have coughing, sometimes with secretions, with sputum. Some patients may not have any symptoms, but it could be picked up because their family doctors are diligent and they have like smoking history. They would do a spirometry to look and screen for this condition, because we want to pick up this condition before it gets symptomatic, because usually it's not very reversible. So it's usually important to diagnose early on.
Okay.
And so you brought up one of the things. So would you agree that there's three main groups of risk factors for these group of people? So smoking for sure is by far the number one. Would the second group be an umbrella of environmental factors like exposures to dust or workplace solvents or those kinds of things, or that would be the other one? And then the genetic one, which is very uncommon but very severe, the alpha-1 antitrypsin disorder.
Right. So for most patients, I would say possibly like 90% are smokers.
Right.
Especially long-standing smokers, 1 to 2 packs daily. But sometimes it may not be as much as that. But it's unlikely that you get COPD just smoking a few cigarettes here and there, but usually at least 10 to 15 pack years. But there are also a second group caused by exposure to pollution, for example, secondhand smoking. We see that a lot, especially in the old days. They live in homes where the parents are heavy smokers. They sit in the car and everyone's smoking in the car with the windows up.
I remember that as a kid.
Yeah, that's right. We all have experienced that, right? And then in developing countries, we're also concerned with the biomass fuel, where they use fuels at home for cooking and heating, maybe wood or some alternative kind of fuel. And it's very smoky and full of soot and things like that. And all the small particles can enter the lungs, just like smoking. And extensive exposure to these pollutants can also result in COPD. We also see sometimes patients with prematurity at birth causing some damage to the lungs. And even children with pneumonia can result in damage to the airways, causing COPD. So we're seeing some patients with no smoking history, and they end up with severe airflow obstruction. That would be the second group. And then there's the third group that you mentioned with the genetic predisposition, the most common one being alpha-1 antitrypsin deficiency, where the lungs are damaged because of the deficiency of this chemical that is not produced. It can also affect the liver and the lungs.
On the secondhand smoke thing, because that's my situation. I never smoked a cigarette in my life. However, I did grow up in secondhand smoke. Is there a way to quantify that? Or if that was so many years ago, has my risk gone back down to baseline now? Or once you've been exposed, you carry that risk for the rest of your life? How does that work?
Yeah, it's very difficult to quantify it because, how exactly do you quantify that? It's all by history and it's almost impossible. But we do know that it makes a difference. The effects are probably not that bad because you're not directly smoking the cigarettes with all the bad things generated from burning cigarettes at thousands of degrees, right? But we do think that there is some improvement with time, especially things like lung cancer. If you haven't been exposed to it for so many years, the risks are perhaps lower, but never back to zero.
Okay.
With COPD, it's a bit different because once you have it, it's irreversible.
Right. Okay. And in this, you don't open a can of worms here, but in the smoking pile, is vaping in there at all, or is vaping a completely different set of lung issues?
Yeah, vaping is another kind of worms. We don't have that much experience or data because vaping is more in the last sort of decade or so.
Newer.
We do know that vaping is not good, and we certainly discourage vaping, except perhaps in the context of patients who really try to quit smoking. They just couldn't do it.
Yeah.
Despite using nicotine patches and all those things that were available to help them, if they really couldn't do it, sometimes we would say perhaps vaping is less dangerous, and some authorities have positioned themselves to suggest using that as a way of trying to get off smoking.
Gotcha.
Certainly, young people, teenagers, we see a lot of them vaping, and we're worried that that's a segue into smoking in the long term, because they're addicted to nicotine, which is often used in the vaping juices. So vaping is not good, and we know, there's this entity called EVALI, e-cigarette vaping associated lung injury, that was first reported back in, I think, 2019.
Okay.
And there are now thousands of patients, including some deaths, mostly in young people, because they're vaping substances that are actually damaging to the lungs.
Okay, maybe another video going into more detail. We did do a video a while ago about vaping, and we did get a lot of comments back from people who seem to love vaping.
Yeah.
So it's good to have a respirologist here to
We don't like that. We don't
to
like
toe the
that.
line here on don't vape. Okay, so in terms of COPD, not really relevant, the vaping thing, but definitely smoking is and secondhand smoke.
Right. So under COPD, we have both emphysema and chronic bronchitis. Is that correct?
Yes, those are the main two entities.
Right. And one of the diagnostic criteria is the duration of the symptoms, right? So if you have bronchitis for 2 weeks, you don't have COPD because you're missing the chronic part.
Yes.
So you go to your family doctor, you've had more than 3 months in the last 2 years, or was that still the criteria, would you say?
Yeah, so that's the criteria for chronic bronchitis.
Yes.
So chronic means long term.
Right.
Right. If you're just coughing for a few days, for a few weeks because you had a cold
Right.
or COVID or whatever,
Yes.
or influenza or RSV, those are the main three viruses now, then that's acute bronchitis.
Right.
Acute. For chronic bronchitis, it's long term. So the definition, as you mentioned, is quite simple: coughing, usually with production of sputum,
Right.
for at least 3 months in a year, at least 2 years in a row.
Okay.
If you do that, you likely have chronic bronchitis.
Right. So you're at your doctor and you had your physical exam, and the physical exam may or may not show something, right? You might hear.
What do we do? So I've had those symptoms that you talked about: shortness of breath, maybe some coughing, or I maybe got picked up asymptomatic. You go to the doctor. What's going to happen on physical exam?
Well, we certainly would examine you, especially listening to your chest. Sometimes you may not find very much. Examination is not particularly sensitive, especially for the mild cases. In fact, you may not find anything. In the severe cases, especially with emphysema, they can have what we call big lungs. And when you sort of check the lung expansion, it's not as big. When you take a big breath, the lung doesn't expand as well.
Okay.
And sometimes the lung goes in sideways, like because of the mechanics of distorted lungs. When you listen to the lungs, sometimes it's quiet. You don't hear the breath sounds as well. Sometimes you can hear some wheezing. You can sometimes hear some gurgling sounds because of the secretions in the airways. Sometimes there are crackles, which is like Velcro crackling sounds in the lungs, to suggest maybe secretions in the airways.
Okay, so the doc's basically going to watch you breathe and listen to you breathe and collect some information about that on physical examination, and then some investigations. And you had mentioned one, spirometry, but anything else? So maybe just tell us again what spirometry is.
Yeah, so the spirometry is the little gadget. They're very small these days, and basically inside it, there's this little device that measures how much airflow there is, how fast air is going through the device. And you take a big breath, and then there's a mouthpiece, seal your lips on it, and just blow out as hard as you can.
Right. Well, that's a hard blow.
Usually 6 or 7 seconds, completely empty out your lungs.
And so that's your FEV, right?
Yeah, so FEV1
Yeah.
is the forced expiratory volume in 1 second.
1 second.
FEV1, how much air you blow out in 1 second.
Right.
Yeah.
And we compare that to the FVC, which is the forced vital capacity, how much air you can blow out from the beginning to the very end in one breath.
Okay.
And usually we look for a ratio of 0.7, at least getting 70% of your full breath out in that first second.
So suffice to say, a bit tricky if you want a career as a clown, where you blow up those balloons and tie them into different animals. Probably gonna need a pump for that.
Well, yeah, especially if you're smoking at the same time, yes. It would be a bit of a-
So now your family doctor's made your diagnosis. They say, we're convinced that you have chronic obstructive pulmonary disease. Do they start treating you, or would they typically send you to a respirologist, or is that a little bit of a dealer's choice?
They don't usually have to send to a respirologist
Okay.
right away, especially if the patient's mild. A lot of counseling to see, whether the patient is smoking or not.
Yep.
The most important thing is to quit smoking.
Number one treatment,
Number
stop
one,
smoking.
Stop smoking or stop exposing yourself to all the fumes, whatever is around you.
Okay.
That's the most important thing because it's irreversible.
Right.
And if you continue to smoke, your lungs will continue to get worse.
So it'll be irreversible and progressive.
And progressive,
Yes.
absolutely. They've done lots of studies to show that it's irreversible despite all the medications we have. Medications can help to reduce symptoms, but it does not reverse the process, unfortunately.
And so the purpose of treatment at this point is to reduce progression, but also to improve your quality of life in the short term, essentially being short of breath.
Yes.
Okay, so are there any medications? Our viewers love big pharmacology. They really love.
No, they don't.
No, they
Our viewers hate big pharma.
So are there any medications that can help someone with COPD to have a better quality of life now that they've quit smoking?
Absolutely.
Okay.
They are basically inhalers or what we call puffers.
Yes.
There are many, many different ones now. I mean, the list is so long, but basically there are several groups. The simplest is what we call the short-acting beta-2 agonist. The salbutamol, Ventolin, which is like a blue puffer.
Right.
It basically relaxes the smooth muscles that goes around and around the airways, so the airways can open up a bit, and then one can breathe a bit easier because the airways are more opened.
Right.
They don't last very long, about 6 to 8 hours, and usually used as needed. So that's the short-acting beta-2 agonist. There's also long-acting beta-2 agonist that lasts like 12 to 16 hours, some of them even 24 hours. So that's usually used once a day as opposed to as needed because it's long-acting. And then there is the antimuscarinic group, or LAMA, which is basically another bronchodilator, but it doesn't work on the beta-2 receptors. It works on different receptors that also allows the airways to open up.
Right.
So there are those two groups that are what we call bronchodilators. And then lastly, there's the steroids group.
Right.
And the steroids are inhaled steroids that help to minimize airway inflammation, because with COPD as well as in asthma, there's a lot of inflammation in the airways. Steroids sometimes is a bad word, but steroids in medicine helps to reduce inflammation. It sometimes can be life-saving, and it's helpful in COPD.
Okay, and then would antibiotics ever play a role in emphysema or COPD, like with the bronchitis side of things?
Generally not. Except in certain situations. For example, when you have what we call an acute exacerbation, meaning that your symptoms are suddenly a lot worse for days and weeks, usually because of a viral infection causing further inflammation in the airways, causing further narrowing of the airways, causing increased sputum production, so you're coughing more breathless. Sometimes in that kind of situation, there's antibiotics with steroids. These are steroid pills, usually for 5 to 7 days, that can help to limit the duration of the COPD exacerbation. In some COPD patients, usually severe with frequent flare-ups, frequent exacerbations, we do put them on one class of antibiotics long-term, using it every day, because that class of antibiotics have been shown to have anti-inflammatory properties that can help to minimize some of the symptoms and, more importantly, minimize the frequency
Which
of
class?
these flare-ups. That's the azithromycin. Which
Oh,
is,
okay.
Yeah,
Good.
azithromycin in particular.
Interesting.
Okay. And then sort of end stage, getting really bad, you've tried all this stuff. When are you looking at oxygen at home or home oxygen? Does people ever get to that?
So absolutely. So we do check patients for oxygen level, and these days it's very convenient. You've all seen the oximeter, that little thing you put in your. You've know that may not be as accurate. That may not be as accurate, but it's pretty good. But there are oximeters that you put on your finger.
Yes.
That small little probe. I'm sure we've all seen that.
Yeah.
That's fairly accurate. and that can quickly tell us what your oxygen level is. So most people often feel when they're short of breath, the oxygen level is low, and that's often not the case.
Not the case, right.
Not the case.
Carbon
So you
dioxide,
can, well, yeah, exactly. You can be short of breath with normal oxygen level. So if I strangled you right now, you get really short of breath, but your oxygen level wouldn't have dropped a single bit, right?
Respirologists are
Yeah.
aggressive.
That's right.
Smart and aggressive.
That's smart and aggressive.
But if your oxygen level is chronically low,
Right.
and also if your oxygen drops to a significant degree with exertion, then yes, we do prescribe oxygen.
Okay.
And are we talking like when it's, because people are going to look and they're going to say, well, my SATs are 97 or 96. Is there a specific target number, or it's a combination of the number and the symptoms?
Most of the time, we like to see it like over 90%.
90.
Or above that is not really going to help very much. Okay. It's not like you need to be 99%, 100%. It's like going to school, you need to be 100% or anything.
Yeah.
Anything usually over
like
the
my
high
parents.
80s.
Yeah, PTSD.
Yeah, exactly. So usually over like 88%, over 90% is adequate. There is a lot of redundancy in the system. The bottleneck is no longer the oxygen once you get it like over 90%. In patients with, well, it's a bit complicated now, but with high CO2 level, we don't like to see it more than 92%. So the lowest number we would pick is usually about 88%.
Okay. And then lastly, as surgeons, I looked into this. And so end stage, there are some theoretical benefits of surgery and three main procedures that I noticed. And it was the bulectomy for the emphysematous patient that has big, large areas that don't have normal alveoli, a lung reduction surgery, or a lung transplant. How often is surgery actually done for COPD?
Oh, it's very rare.
It's very uncommon,
very
right?
rare. Yes, yes.
Because it's high risk and the patients are
Yes,
complicated.
High risk, absolutely. I think I would say less than 1%.
Yeah, so this is not something that if you have COPD that you should be thinking, I'm just going to get surgery after it's all said and done.
Yes.
It's really not a very viable option for most people.
No, and especially lung transplant.
Yeah.
No, if you're in your 70s and 80s, you're not going to get lung transplant
Right.
for COPD. If you're in your maybe 30s, 40s, 50s, maybe in your 60s, and you have really bad lungs and you just really poor quality of life,
Yeah.
and you're otherwise healthy, that may be considered.
Sure.
And often we see that in that genetic group.
Right.
With alpha-1 antitrypsin deficiency, where they can get COPD, in their 40s and 50s.
Yeah.
Those are patients that we may consider lung transplant.
Okay.
Wow, that
That's
is
a
a
lot.
big. They were right. Respirologists are way smarter than orthopedics.
Right, too.
It's not a myth.
That was an excellent summary, and I think it's going to help clarify some things for our patients. So now you know, if you have COPD, if you have symptoms like this, talk to your doctor about COPD.
And remember, you are in charge of your own health. And if one of our viewers quit smoking because of this, then it was a success.
I would agree.
Absolutely.
Thanks, Dr. Chow, for joining us, and we'll see you next time.